Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You step into an operating theater for a routine appendectomy, and there is a really comforting rhythm to it.
Yeah, absolutely. It's deeply ingrained muscle memory for most general surgeons.
Right. It's a baseline expectation of like a very predictable chaos. You expect to find this inflamed, angry little worm of an appendix. You isolate it, clip the base, remove it, wash out the area, and close up the patient.
Exactly. I mean, the pathology is overwhelmingly assumed to be just straightforward acute inflammation.
It's the definition of bread and butter general surgery.
Yeah.
But imagine you put the laparoscope in, the monitor lights up, and instead of that angry little worm, you find this massive, swollen, translucent cylinder.
Oh, wow. Yeah.
That looks like it's made of solid gelatin.
Your heart rate just instantly spikes because in that split second, the margin for error in that operating room drops to absolute zero.
It really does.
If you handle that gelatinous cylinder the wrong way, you turn a localized, manageable problem into a completely diffuse, life-threatening catastrophe.
Yeah, you're suddenly staring down an unexploded bomb. Because if that fragile capsule bursts, it spills highly invasive cells throughout the entire abdominal cavity, which sparks this devastating condition called pseudomyxoma peritoniae.
Right, which is a nightmare scenario.
It really is. And that brings us to the core mission for today's deep dive. So welcome to all the surgeons, medical doctors, and, clinical listeners joining us today. This one is highly clinical, designed specifically to sharpen your approach to a rare but incredibly high-stakes encounter, the appendiceal mucocele.
It's a topic that demands absolute precision.
Completely. But before we go any further, I just need to state a mandatory disclaimer. This content is strictly for reference and educational purposes only. You must always follow your local clinical guidelines and institutional protocols in your own practice.
Yeah, that is definitely crucial to remember.
For sure. Okay, let's unpack this. We are talking about an anomaly that only shows up in roughly 0.2 to 0.4% of all appendectomy specimens. It's a macroscopic term, meaning it's literally just a mucus distended appendix. But why is a simple buildup of mucus considered such a severe threat?
Well, the danger lies entirely in the cellular makeup of that mucus. I mean, in a significant portion of these mucoceles, specifically the neoplastic subtypes, the mucus isn't just inert fluid.
Right, it's not just water.
Exactly. It is loaded with abnormal mucin-producing epithelial cells.
The best visual I have for this is like a hyperfragile water balloon.
Yeah.
But instead of water, the balloon is packed to the brim with thousands of invasive weed seeds suspended in a thick jelly.
That is a terrifyingly accurate analogy.
Right, and if that balloon pops, whether it ruptures spontaneously before the patient even reaches the hospital, or iatrogenically because, a surgeon squeezed it with a metal grasper, those seeds scatter across the peritoneum.
And what's really fascinating here is the sheer relentless nature of those seeded cells. Once they take root on the peritoneal lining, they simply do what they were programmed to do.
Which is just make more mucus.
Yes. They secrete massive amounts of mucin. This creates pseudomyxoma peritoniae, or PMP. The abdomen literally fills with thick, gelatinous ascites. In the surgical world, we often refer to it colloquially as jelly belly.
Wow, jelly belly.
Yeah, and it coats everything. The bowel, the liver, the diaphragm.
Which eventually compresses the internal organs. Right. I mean, patients essentially starve because their gastrointestinal tract becomes entirely encased in this inflexible jelly.
That is the grim reality of untreated PMP, yeah. Now, the prognosis heavily depends on the biological grade of the cells that actually escaped.
Forget how so.
Well, if the rupture stemmed from a low-grade tumor, it results in low-grade mucinous carcinoma peritoniae. The cells aren't deeply invading the surrounding organs, but they are producing oceans of mucus.
So it's a huge mess.
A monumental surgical cleanup, definitely. But the biology itself is less aggressive.
But if those cells are high grade, meaning they came from a mucinous adenocarcinoma, the behavior completely changes.
Drastically. High-grade cells don't just sit on the surface making jelly. They actively burrow into the tissues, they spread through the lymphatic system, and the mortality rate just skyrockets.
Wow.
Yeah, the difference in 5-year survival is stark. That is exactly why keeping the specimen completely intact during removal is the holy grail of this entire clinical scenario.
Right, so if the stakes are a potential lifetime of PMP, It seems obvious that a surgeon needs to know this trap is waiting for them before they make the first incision.
Ideally, yes.
But clinically, that is a massive problem. I mean, these patients walk into the emergency department mimicking garden variety appendicitis, right? Iliac fossa pain, maybe a slight fever. So how is a clinician supposed to spot the anomaly when the clinical picture is screaming standard appendicitis?
You really cannot rely on the physical exam. You have to rely heavily on preoperative imaging. A surgeon must actively look at the scans with a really high index of suspicion, rather than just passively reading the radiologist's summary.
Okay, so let's break down the mechanics of spotting this on a scan. If a patient gets a standard ultrasound, what is the specific red flag?
You will initially see a well-defined cystic lesion in the right lower quadrant, but the absolute hallmark is a phenomenon we call onion skin echoes inside the cyst.
Onion skin echoes. I see that term constantly in the literature. But what is physically happening with the ultrasound waves to create that visual pattern?
It comes down to acoustic impedance. So as the tumor grows inside the appendix, it secretes mucin in distinct cyclical phases.
Like turning on and off?
Sort of, yeah. Over time, you get alternating layers of dense, highly cellular mucin, followed by layers of less dense acellular mucin piling up inside the lumen.
Oh, I see.
Right, so when the high-frequency sound waves from the ultrasound probe hit those layers, they bounce back at different velocities based on the density. The machine translates those varying echoes into a laminated swirling pattern on the screen.
And it looks identical to the concentric rings of a sliced onion.
Exactly.
So the waves are literally mapping the geological strata of the mucus. That is brilliant. What about a CT scan? Because that is usually the standard diagnostic tool for adult right lower quadrant pain.
On a CT, you are looking for a low attenuation tubular mass that's contiguous with the cecum. The mucus just shows up as a dark, fluid-filled space.
Okay.
But the red flag you absolutely cannot ignore is the presence of curvilinear calcifications along the wall of that mass.
Wait, why does the wall calcify? Is the tumor itself producing calcium?
No. It's a structural response to chronic biomechanical stress. The appendix has been distended by this massive volume of mucus for months, sometimes even years.
So this is just stretched to the max.
Yes. The wall undergoes chronic inflammation and microscopic ischemia as it's stretched to its absolute limits. And in response to that smoldering injury, dystrophic calcification occurs.
Oh, wow.
So if you see a calcified rim around a tubular mass sitting off the cecum, your brain must immediately flag it as a mucocele.
Okay, so we have identified the mass. We know we are dealing with a mucocele.
Right.
But here's where I have to push back a little on the literature.
Okay.
The World Health Organization updated their classification system for these tumors in 2019. And they threw out older terms like mucin-assisted adenoma.
They did, yeah.
Why bother changing the name?
Yeah.
I mean, surgeons knew what assisted adenoma was. Doesn't changing established terminology just create unnecessary confusion in a high-stress clinical environment?
Well, this raises an important question, and frankly, there was definitely resistance from the surgical community initially.
I bet.
But the change was absolutely necessary because the old terminology was actively dangerous.
Dangerous. How so?
Because the word cystadenoma inherently implies a completely benign, harmless entity. Yet, as we just discussed, if a so-called benign cystadenoma ruptures in the abdomen, it can still seed the peritoneum and cause fatal PMP.
Ah, I see.
Right. So the WHO needed a classification spectrum that accurately communicated the biological risk to the surgeon.
That makes a lot of sense. So instead of a binary benign versus malignant label, we now have this 4-tier pathological spectrum. Let's trace how this disease evolves from a simple mechanical issue to a sinister malignancy.
Sure. At the baseline, we have type 1, the simple or retention mucocele. Now, this is not a tumor. It's basically a plumbing problem.
Like a blocked pipe?
Exactly.
Yeah.
A phacolith, which is a hard piece of stool, blocks the appendiceal orifice. The mucosal cells behind the blockage are completely normal, but they just keep producing fluid. It has nowhere to go, so the appendix balloons.
Right, so the cells are behaving normally. They are just trapped.
Yes. And closely related to that is type 2, the hyperplastic or serrated lesion. Here, you have a slight overgrowth of cells, like a polyp, producing excess mucin.
But no severe dysplasia yet.
Correct. No overt neoplasia. If either of these first two types are removed intact, the patient is essentially cured.
Okay, but here's where it gets really interesting. Type 3. The LAMN, or low-grade appendiceal mucinous neoplasm.
Yes, the LAMN.
This is the single most common culprit behind PMP. But I struggle with the terminology here too, to be honest. The name low-grade sounds misleading if it's the main driver of such a devastating peritoneal disease.
I get that. But low grade only refers to the cytology, like the cells themselves don't look highly mutated under the microscope.
Yeah.
But their structural behavior is incredibly destructive due to a unique mechanism called pushing invasion.
Twitching invasions.
Yeah. Most typical cancers aggressively chew through surrounding tissue using enzymes. Lamin does not do that. It secretes thick mucin that steadily builds immense internal pressure, essentially elbowing its way through the muscle layers of the appendix wall.
Wow, so it is a mechanical destruction rather than a chemical one.
Precisely. And as it pushes, it completely destroys the normal, elastic, smooth muscle of the appendix and replaces it with mural fibrosis.
Okay, I see how that changes the physics of the organ entirely. I mean, the normal appendix wall is muscular, right? It can handle some distension.
Right.
But the Lannan replaces that elastic muscle with dense, inflexible collagen and scar tissue.
Which cannot stretch. It only tears.
That is terrifying.
It is. That mural fibrosis is the exact reason these lesions are so incredibly fragile. The wall becomes this brittle, paper-thin shell holding back highly pressurized mucus. It is actively being pushed to its breaking point from the inside out.
Which brings us to the top of the WHO spectrum, type 4 HMN, the high-grade appendiceal mucinous neoplasm, or just frank mucinous adenocarcinoma.
Yeah, this is where the biology turns overtly hostile. The cells are highly mutated now. They abandon the slow-pushing technique and adopt true infiltrative invasion.
So they start chewing through things.
Really? Exactly. They chew directly into the blood vessels, the lymphatic channels, and the surrounding mesoappendix. AAP-men is not just a balloon waiting to pop. It is a rapidly spreading malignancy requiring a massive oncological resection.
But this highlights the ultimate trap for the surgeon standing at the operating table. When you are looking at this distended, translucent cylinder on your monitor, you have absolutely no idea which of those 4 types it is, do you?
No. You cannot visually distinguish a harmless retention mucocele from a highly malignant OMN. You are entirely blind to the histology.
That's wild.
Yeah, the definitive answer won't be known until the pathologist stains the tissue and examines it days later.
Therefore, your surgical approach must fundamentally assume the absolute worst-case scenario.
Always.
Every single mucocele must be treated as if it is a high-grade cancer waiting to seed the abdomen. So how do we navigate that physically in the OR? What are the absolute golden rules of resection?
Total, strict no-touch isolation. You cannot put a fenestrated grasper anywhere near the dilated portion. The fibrotic tissue is far too friable.
So you don't even touch the mass itself?
Never. You handle the periappendiceal fat. You manipulate the cecum to move the appendix by its base, but you never directly grasp the mucocele, and you absolutely must retrieve it in a heavy-duty surgical endo bag.
To prevent any contact with the abdominal wall during extraction, right?
Exactly.
But this sparks a major technical debate in the surgical community. If this thing is so fragile, how does a surgeon safely remove a 10-centimeter balloon through a 1-centimeter laparoscopic port?
Right, that's the big question.
I mean, the old school traditional teaching was that you must do a laparotomy, like a massive open abdominal incision, to avoid popping it.
Yeah, and the historical fear went beyond just the size of the extraction port. It was centered around the pneumoperitoneum.
The carbon dioxide gas pumped into the abdomen.
Right, to create working space during laparoscopy. The theory was that if the mucocele ruptured while the abdomen was under pressure, the gas dynamics would act like an aerosol can, blasting the mucinous tumor cells into every microscopic crevice of the peritoneal cavity.
Oh, man. So a localized spill would instantly turn into a hurricane of cancer cells.
Exactly. That was the fear keeping surgeons up at night. But robust contemporary data has completely shifted the paradigm.
Really?
Yeah. We now know that minimally invasive surgery, whether it's pure laparoscopic or robotic, is highly safe and oncologically sound, even for massive mucocilus measuring over 15 centimeters.
Wow, 15 centimeters.
Yeah. The aerosolization risk is heavily mitigated, provided the capsule remains completely intact.
But how do you actually get it out of the body without crushing it? I mean, you cannot drag a massive pressurized bag through a tiny hole. It will rupture right in the abdominal wall.
Well, you don't try to force it. That is a critical technical error.
So what's the trick?
Once the specimen is safely isolated inside an impermeable retrieval bag, you bring the neck of the bag up to the abdominal wall. Then you use your scalpel to deliberately enlarge the port site incision. You literally make the exit wound as big as the specimen dictates, and you slide it out gently.
Okay, so minimally invasive is acceptable, but the threshold for abandonment must be razor thin.
Oh, absolutely.
What is the exact scenario where a surgeon needs to swallow their pride, look at the surgical team, and say, we are converting to open?
You convert the second you lose absolute confidence in your ability to protect the capsule.
No hesitation.
None. If there are dense inflammatory adhesions fusing the mucocele to the retroperitoneum and you realize you have to tug or pry at the mass, you convert.
Makes sense.
If the lesion is so massive that it obscures your camera view and you cannot safely navigate your instruments, you convert. A larger scar on the patient's abdomen is infinitely preferable to subjecting them to a lifetime of pseudomyxoma peritone.
Such a great point. Okay, so fast forward a week. The unexploded ordnance is out, intact in a bag. The patient is recovering well, then the pathology report lands on your desk.
The moment of truth.
This is where the unseen histology dictates the patient's future. Let's say the report says it was a simple mucocele or a lamb that was totally confined to the appendix, and you got clear margins. Is the surgical journey over?
If the base of the appendix, the margin where you cut it away from the cocum, is completely free of tumor cells, then yes, an appendectomy is considered curative in that case.
What if the tumor was sitting right on the base, or was a type 4 HAM?
Then you have not achieved source control. The patient must return to the theater. For a broad-based lamb involving the cecum, you might perform a partial cystectomy.
And for the AM?
For an AM or an adenocarcinoma, standard oncological principles dictate a formal right hemicolectomy. You remove the entire right side of the colon and harvest all the regional lymph nodes to check for lymphatic metastasis.
Brutal, but necessary. What if the absolute worst-case scenario occurred? What if the pathologist finds mucin on the outside of the appendix, or the surgeon noted jelly-like nodules on the peritoneum during the initial scope?
That patient has established PMP, and they require an immediate referral to a highly specialized center for cytoreductive surgery and HIPEC.
Let's pause on that because CRS and APEC is one of the most extreme, physiologically demanding interventions in modern surgery.
Without a doubt.
Cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. What does that actually entail for the human body?
It is an absolute marathon operation. The cytoreductive phase involves the surgical team methodically stripping away the diseased peritoneal lining from the abdominal wall, the diaphragm, and the pelvis.
Just literally peeling it away.
Yeah. They resect any organ coated in tumor, the gallbladder, the spleen, segments of the bowel. They painstakingly reduce the visible tumor burden down to microscopic levels.
And then comes the HIPEC phase.
Yes. They insert catheters, temporarily close the skin, and circulate a heated chemotherapy solution directly throughout the abdominal cavity for 60 to 90 minutes.
Wait, how hot are we talking?
Usually around 42 degrees Celsius or 108 degrees Fahrenheit.
That is intensely hot. Why heated, though? Does the temperature physically melt the residual tumor cells?
It acts synergistically. The heat has a direct cytotoxic effect, damaging the DNA and disrupting the lipid bilayer of the cancer cells. But more importantly, the heat causes extreme local vasodilation and increases the permeability of the tumor tissue.
Oh, it opens them up.
Exactly. It essentially forces open the pores of the microscopic disease left behind, allowing the chemotherapy drugs to penetrate much deeper into the tissue than they ever could at normal body temperature.
That is just staggering. It really reinforces just how vital that initial no-touch appendectomy really is. You are literally trying to save someone from having their abdominal cavity stripped and bathed in boiling chemotherapy.
Yeah, and if we connect this to the bigger picture, there is another hidden trap here that catches many clinicians off guard, even if that initial appendectomy went perfectly.
Asynchronous lesions.
Yes, there is a deeply documented association between neoplastic appendiceal mucocele and other primary tumors, most notably in the colon and the ovaries.
Wait, real?
Statistics show that up to 20 to 30% of patients with an appendiceal mucocele have a synchronous colorectal cancer growing at the exact same time.
Why is that? Are the cells from the appendix traveling to the ovaries or the colon?
No, they are entirely separate primary tumors. The exact mechanism points to a shared embryological vulnerability. The tissues of the appendix, the right colon, and the ovaries share certain developmental pathways.
Oh, I see.
So a genetic hit or mucosal defect that triggers a mucinous neoplasm in the appendix often signals a high-risk field cancerization environment for a synchronous tumor nearby.
So you could perfectly execute the mucocele extraction, congratulate your team, and completely miss a silent colon cancer growing just a few inches away.
Exactly, which is why the clinical workup is never finished in the operating room. If the pathology confirms a neoplastic mucocele, standard protocol dictates the patient must undergo a complete colonoscopy.
And for female patients?
A comprehensive pelvic ultrasound or MRI is absolutely mandatory to evaluate the ovaries.
The vigilance simply doesn't stop.
It really can't. And that extends to the long-term follow-up protocols too. Benign retention mucoceles just need routine post-op care. But for a lamb, especially if a cellular mucin was noted near the serosa, you are tracking them with cross-sectional imaging for years.
Because the PMP risk just lingers.
Exactly. And for a HAMA or adenocarcinoma, it is aggressive oncological surveillance. CT staging of the chest, abdomen, and pelvis, and serial tracking of tumor markers like CEA and CA19-9.
Multidisciplinary review is practically mandatory for these cases, isn't it? You need the surgeon, the pathologist, the radiologist, and the oncologist all sitting at the same table, decoding the nuances of the cells.
Absolutely. The difference between a simple surveillance scan and a massive right hemicolectomy hinges entirely on a very precise, collaborative reading of that histology.
Wow. So what does this all mean? I mean, if we zoom out, it's a radical reframing of how we view our own anatomy. In medical culture, the appendix is so often dismissed as this useless vestigial tube.
Right, an evolutionary leftover.
Exactly. Something we only think about when it acts up and needs to be tossed in the biomedical waste bin. But in the context of a mucocele, that little vestigial tube reveals itself to be a complex, highly dangerous epicenter.
It demands a complete mental shift. The person holding the scalpel has to stop acting purely as a technician focused on speed and start thinking synchronously as an oncologist, a radiologist, and a pathologist.
It requires profound situational awareness. Diagnose the acoustic shadows, respect the brittle scar tissue of the pushing invasion, handle the organ with absolute reverence, and let the unseen cellular biology dictate your every move. It is a fascinating masterclass in why there is truly no such thing as a routine surgery.
Could not have said it better myself.
Well, to all our clinical listeners tuning in, we hope this deep dive arms you with the precise nuances you need the next time you spot onion skin echoes on a Friday night scan, or find yourself staring at a translucent surprise in the right lower quadrant. If you found this content valuable, please do not forget to share it with at least one colleague or friend. Spread the word, because raising awareness on these rare high-stakes pathologies absolutely saves lives. Also, make sure to check out our YouTube and other social media pages for deeper dives and visual breakdowns of the topics we cover. And if you haven't already, check out our previous season and past episodes where we explore some very relevant medical topics that tie right into today's discussion.
There's always more to learn beneath the surface.
Always. So, we leave you with this final thought to mull over. If a seemingly useless organ like the appendix can harbor a mechanism complex enough to orchestrate the biological destruction of the entire peritoneal cavity, what other vestigial structures in the human body are we radically underestimating?
That's a chilling thought.
The next time you prep for a standard, straightforward appendectomy, ask yourself, are you truly ready for the bomb disposal? Thanks for listening.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.